Great. Thank you very much. So this is the title of my talk, as suggested by Serge. I had an alternative title. If I can figure out how to, there we go. And I'll leave it to you at the end of the talk to decide whether the question mark belongs there or not. So the myeloproliferative neoplasms have been updated and rearranged a little bit in the latest iteration of the WHO classification. And they now include chronic myeloid leukemia, the traditional BCR-ABL rearranged variety, chronic neutrophilic leukemia, which for those of you who are as old as I am may recognize that this is an appropriated name for a disease that used to be characterized also by BCR-ABL translocation with the P230 gene product, but now refers to a disease with the CSF3R mutation, which is might be better known as mutation in the receptor to GCSF. The MPNs also include Polycythemia Vera, ET, myelofibrosis, chronic eosinophilic leukemia, as Jason just mentioned, and mastocytosis, which used to be fully under the subheadings of the other MPNs, is now recognized as an MPN, but somewhat more removed from the other group. The rest of my talk today will focus on the traditional MPNs of PV, ET, and myelofibrosis. Before I discuss them, though, it's probably important to recognize that there are other diseases with myeloproliferative characteristics, and Jason just very eloquently discussed the diseases associated with eosinophilia. There are also the myelodysplastic myeloproliferative neoplasms that are probably the ugly stepchildren of hematologic oncology, including chronic myelomonocytic leukemia and atypical chronic myeloid leukemia, diseases that don't fit as nicely into our disease classification systems. The findings that were really the basis to prompt revision of the WHO classification included the identification of new molecular drivers, especially the calreticulin mutation, the recognition that mutations in CSF3R were strongly associated with chronic neutrophilic leukemia, the feeling that Polycythemia Vera was possibly underdiagnosed with the threshold hemoglobin hematocrit levels in the 2008 criteria, the idea that essential thrombocythemia needed to be differentiated from prefibrotic primary myelofibrosis, and that there needed to be clarification of the prefibrotic myelofibrosis minor diagnostic criteria. And they also made an attempt to standardize the morphologic MPN criteria. So just to know where things were prior to the spring when the new diagnostic criteria were proposed, the Polycythemia Vera criteria from the 2008 WHO classification included the presence of of hemoglobin 18.5 in men or 16.5 in women, or other evidence of increased red cell volume. And I know that Dr. Silver, I think, is one of the last proponents of red cell mass studies, but that's just another way to identify increased red cell volume, the presence of the JAK2 mutation, and then as minor criteria, hypercellular bone marrow with trilineage growth, which they're now really articulating as panmyelosis, low serum erythropoietin, and endogenous erythroid colony formation in vitro. And in order to make the diagnosis, you needed to have both major criteria or an elevated hemoglobin and 2 minor criteria. And we heard earlier this morning that it's certainly possible to have polycythemia vera without having a JAK2 mutation. In the 2016 revisions, they lowered the hemoglobin diagnostic criteria to 16.5, to 16.5, I'm doing this, 16.5 in men and 16 in women, and had hematocrit correlates. They moved the finding of panmyelosis from a minor criteria to a major criteria, and again kept the JAK2 mutation status as a major criterion. They removed endogenous erythroid colony formation in vitro, and this was obviously prompted by, I think, the well-known experience that this is not really a CLIA-approved test, and I think outside any research laboratory, this was not something that was really easily accessible. And now to make a diagnosis, you either need to have all major criteria or the first major criteria, so elevated hemoglobin or red cell mass, and the panmyelosis, as well as the single minor criterion. I see we have additional music. I think this is better than the music that we had for the questions, though. So one of the, I think the thing that really prompted moving the bone marrow morphology to the major criteria is that as you move the hemoglobin diagnostic criteria closer to the normal range, you need to have an additional test to be able to differentiate that from a reactive erythrocytosis. And I will also point out for the purposes of the questions later that the major criteria was 16.5 in men and 16 for women. The WHO did, however, acknowledge that in the setting of high hemoglobin or hematocrit, that a bone marrow examination may not be needed to make the diagnosis. There probably aren't that many other diagnostic possibilities in individuals who have a JAK2 mutation and low serum erythropoietin. But they also made the comment that there could be some prognostic value in performing the bone marrow examination, noting that patients who have myelofibrosis generally have more rapid progression to overt myelofibrosis. The counterpoint to that, though, is it's unclear whether there's anything that can be done therapeutically at this point to prevent that, although that is an area of ongoing study. Moving on to essential thrombocytosis, the WHO diagnostic criteria from 2008 included a platelet count greater than 450,000, and some of you may remember that the 2001 diagnostic criteria were 600,000. So this, again, is retaining the former threshold. Bone marrow showing panmyelosis, exclusion of other MPNs, including CML and polycythemia vera, the finding of a JAK2 mutation or other clonal marker, or in the absence of a clonal marker, no evidence of reactive thrombocytosis, and that all of these needed to be present to establish the diagnosis. And at this point, I'm just going to rekindle your memory of Dr. Spivak's talk, where he noted that there are a lot of different conditions that can cause elevated platelet counts, and it's important to remember that things including iron deficiency, infections, and I'm sure many of you have had consults to evaluate essential thrombocythemia in patients who are post-splenectomy. So there are a number of components to reactive thrombocytosis, including other MPNs. In 2016, the major criteria for diagnosis retain the threshold of a platelet count greater than 450,000 sustained over at least 2 months. They've clarified the bone marrow findings showing panmyelosis and have suggested that only minor increases in reticulin fibrosis are allowed within the diagnostic criteria. Again, exclusion of the other MPNs, and have updated the molecular genetic findings to include the finding of calreticulin mutation, or MPL. And as a minor criterion, have noted that other clonal markers can be present, or in the absence of other clonal markers, no evidence of reactive thrombocytosis. And in order to establish the diagnosis, you need either all 4 major criteria or the first 3 major criteria and the minor criterion. Moving on to primary myelofibrosis, the 2008 diagnostic criteria included a hypercellular marrow with megakaryocytic atypia, with reticulin and or collagen fibrosis. And in the absence of significant reticulin fibrosis, there needed to be megakaryocytic changes that were accompanied by increased cellularity with increased granulocytic proliferation and often decreased erythropoiesis. Again, as in essential thrombocythemia, other MPNs had to be excluded, and there needed to be the presence of either the JAK2 mutation or other clonal markers, and or in the absence of these, no evidence of reactive fibrosis. The minor criteria, which could be either borderline or marked, included leukoerythroblastic changes, elevated LDH, anemia, or splenomegaly on physical exam. And a little bit like a Chinese menu, you needed all major criteria and 2 minor criteria to make the diagnosis. And again, to remember, there are many different things that can cause reactive fibrosis, including the other MPNs, acute leukemias, lymphoproliferative diseases, including hairy cell leukemia and Hodgkin's disease, and infections and reactive processes, including benzene toxicity and radiation exposure. In 2016, the WHO has now introduced the notion of a pre-primary myelofibrosis. And this includes patients who have megakaryocytic atypia without reticulin fibrosis greater than grade 1, and we'll go through the grading in just a minute, with increased age-adjusted cellularity, with increased granulocytic proliferation and often decreased erythropoiesis, exclusion of the other MPNs, and the presence, again, of these updated clonal markers, or in the absence of a clonal marker, no evidence of reactive fibrosis. And the minor criteria have been adjusted to include leukocytosis with a white count greater than 11, elevated LDH, anemia not attributed to a comorbid condition, and palpable splenomegaly. And to make the diagnosis, you need all the major criteria and 1 minor criterion. This is distinguished from overt primary myelofibrosis now by requiring, with overt primary myelofibrosis, having grade 2 or 3 fibrosis, and also adding in an additional minor criterion of leukoerythroblastosis. And to make the diagnosis, you need all the major criteria and 1 of the minor criterion. Just as a reminder, leukoerythroblastosis is a situation where the blood looks a lot like bone marrow, where you see early progenitor cells of multiple lineages in the peripheral blood, often with teardrop red cell morphology, and sometimes with giant platelets, and more rarely with circulating megakaryocytes. The other clonal abnormalities that are associated with myelofibrosis and ET include ASXL1, EZH2, TET2, IDH1 and 2, SRFF2, and SF3B1. And if you remember, one of the diagnostic challenges with these diseases is that these overlap with the mutations that are frequently seen in MDS and AML. With regard to the grading of myelofibrosis, they've articulated the grading somewhat, and schematically, patients who just have scattered reticulin fibrosis, which will be considered normal, have a grading of 0. Grading of 1 includes reticulin fibers that frequently intersect. For MF2, those fibers frequently intersect and also include large bundled fibers. And for grade 3, in addition to increased numbers of large bundled fibers, there's also the presence of collagen fibrosis. And they recommended collagen staining for patients who have grade 2 or 3 fibrosis. There are a number of issues that really remain unaddressed in the new revision. And one of the challenges, especially for diseases that have natural histories of decades, is that when you change the definition of the disease every 8 years or so, it can alter who gets put into clinical studies that are longitudinal. As somewhat of a pet peeve for, I guess, a small minority of us who treat histiocytic diseases, which I think are full members of this diagnostic classification, they're not included. They articulated criteria for accelerated CML in the revision, but didn't describe accelerated phase disease of the MPNs. And I think many of us recognize that there is a period of time, as particularly myelofibrosis progresses to acute leukemia, that the disease behaves in a more aggressive fashion that's really distinct from the acute leukemia, but not like the typical MPN. The genetic data is not a component of the classification, unlike what the WHO has done for AML. And just as a quick reminder, patients who have calreticulin mutation have a different clinical presentation with regard to anemia, thrombocytopenia, leukocytosis than patients who don't have any of the 3 most commonly associated MPN mutations. And that this is carried over not only to the phenotype presentation, but also to the natural history of disease. And patients who have the so-called triple negative MPNs have a natural history, have an average survival that's really only 1/5 of patients who have calreticulin mutation. There is still ongoing overlap between essential thrombocythemia and primary myelofibrosis. And if you just compare the major criteria, the difference really seems to hinge on the platelet count that's seen in essential thrombocythemia and in the possibility of anemia for primary myelofibrosis. And so it may be challenging to really still distinguish these entities with clarity. There's also substantial overlap between MDS with fibrosis and myelofibrosis. And just to point this out, there are, in essential thrombocythemia, the megakaryocytes are typically clustered, and you see a range of megakaryocytic maturation, including hypolobulated forms, which many pathologists will describe as dysplastic. And As an example, in the entity known as MDS-MPN with ring sideroblasts and thrombocytosis, that's characterized by SFB1 mutation. Often there is elevated platelet count and greater than 15% ring sideroblasts and erythroid dysplasia. But many of these patients also have JAK2 mutation, and less commonly MPL or calreticulin mutation. And so which of these genetic features is really driving the disease, and how they should be best clarified, I think is still a contentious point. So in summary, the new revised MPN classification decreases the hemoglobin and hematocrit threshold for polycythemia vera, includes updated mutational information, especially with regard to calreticulin, and introduces the notion that pre-primary myelofibrosis is a distinct diagnostic entity. And with that, I'll close. Thanks.